Good morning, one and all. I'm Dr. Sharan Nair from Department of Conservative Dentistry and Endodontics, my Institute of Dental Sciences. Today's lecture is on endodontic emergencies. Moving on to the definition, endodontic emergencies are circumstances associated primarily with pain and or swelling that requires immediate diagnosis and treatment. Most of the emergencies are unscheduled. The reason for endodontic emergency treatment is pain and swelling from pulpo-periapical pathosis. They're mainly classified into three types. We have the pre-endodontic emergencies, emergencies during treatment or inter-appointment flare-ups, and finally you have the post-endodontic emergencies. Moving on to the pre-endodontic emergencies, acute irreversible pulpitis, acute irreversible pulpitis, acute reversible pulpitis, acute apical periodontitis, acute alveolar apis, acute periodontal abscess, cracked tooth syndrome, crown fracture, root fracture, tooth avulsion, and referred pain. Post-endodontic emergencies are vertical fracture, over obturation, or under obturation. Acute reversible pulpitis is defined as it is a mild to moderate inflammatory condition of the pulp caused by noxious stimuli in which the pulp is capable of returning to the uninflamed state following removal of the stimulus. It is characterized by sharp pain lasting but a moment, more often brought on by cold than hot food or beverages. The patient can identify the tooth as in they can pinpoint from where the pain is coming, momentary pain that subsides on removal of stimulus. Now the causes are trauma as from a blow or from a disturbed occlusal relationship, thermal shock as from preparing a cavity with dull burr or keeping the burr in contact with the tooth long, or from overheating during polishing a filling, excessive dehydration of a cavity with alcohol or chloroform, or irritation of exposed dentine at the neck of a tooth, placement of a fresh amalgam filling in contact with or occluding a gold restoration, chemical stimulus as from sweet or soft foodstuffs or from irritation of a silicate or self-curing acrylic filling, bacterial as from caries. Moving on to the treatment, the best treatment is prevention. It is recently restored. In a recently restored teeth, occlusion is adjusted. In cases of marginal leakage or secondary caries, the old restoration are removed and replaced with sedative cement. Pain usually disappears within several days. If it persists, then pulp has to be extirpated. That is, a root canal therapy has to be done. Moving on to the next is acute irreversible pulpitis. We have seen acute reversible pulpitis. Now is the next one. The definition of acute irreversible pulpitis is that it is a persistent inflammatory condition of the pulp, symptomatic or asymptomatic, caused by a noxious stimuli. Acute irreversible pulpitis exhibits pain usually caused by a hot or cold stimulus. The pain is sharp, piercing, or shooting, and it is generally severe. Abnormally responsive to heat or cold tests. Pain occurs spontaneously. Pain lasts for several minutes to hours and lingers even after removal of stimulus. Nocturnal pain, pain or bending or lying down position. The most characteristic feature of acute irreversible pulpitis is the nocturnal pain. Treatment is obviously pulpectomy. You have to anesthetize the tooth. Access cavity is prepared and the canal is located, and the pulp is extirpated from the canals. Cleaning and shaping along with the use of irrigation solution like sodium hypochlorite. Pain persists if inflamed pulp remains in the root canal because inflammatory process will extend into periradicular tissues. Close dressing is given, and most importantly, the occlusion should be relieved so that there is no pressure acting on the tooth under treatment. Moving on. Next one, we have the acute apical periodontitis. Okay. Definition. It is a painful inflammation of periodontium as a result of trauma, irritation, or infection through root canal, whether the pulp is vital or non-vital. The causes of acute apical periodontitis can be occlusal trauma, wedging of foreign objects, blow to teeth, over-inflammation, or overfilling. The symptoms are pain and tenderness of the tooth. Sometimes the tooth may be extruded. The treatment is, if it's a vital tooth, it is symptomatic, we'll have to see the clinically situation and go for deciding a treatment plan. If it is non-vital, it's simple, you go for a root canal therapy. Moving on to the next one is acute alveolar abscess. It is a localized collection of pus in the alveolar bone at the root apex. following pulp death with extension of infection through apical foramen into periapical tissues. It is accompanied by a severe local reaction and at times general reaction of systemic toxicity such as elevated temperature, dizziness, malaise, nausea, lack of sleep, headache, etc. Patient may present with no swelling with intraoral sinus or with swelling. Facial symmetry will be altered and it will be clearly visible. This is what it can look like. Moving on to the treatment, removal of the necrosed pulp, cleaning and shaping of the root canal, placement of calcium obturation of the root canal in the next visit. These steps will restore tooth to functional health. In cases where the periapical drainage cannot be established, a surgical trephination is done. Trephination is the surgical perforation of an alveolar cortical plate over the root end to release the accumulated tissue exudate that is causing pain. A small vertical incision is made adjacent to the tooth, the mucosa is extracted, and number 6 round burr is used to penetrate cortical plate. This provides a drainage. Recent techniques involve use of engine-driven perforator to enter the medullary bone without the need of incision. With swelling, if there is a swelling, then there are 3 ways to resolve it. Establish drainage through root canal, establish drainage by incising a fluctuant swelling. If the swelling is hard, rinse it 3 to 5 minutes with hot saline. Antibiotics, use of antibiotics as an aid to drainage. Incision and drainage is the most important treatment, and antibiotics, like they say, is only an aid to this incision and drainage. Incise at the site of greatest fluctuancy. The clinician should dissect gently through deeper tissues and thoroughly explore all parts of abscess cavity. To promote drainage, the wound should be kept clean with hot water mouth rinses. Next, we have the acute periodontal abscess. Again, the clinical symptoms are pain and swelling. It is usually mistaken for acute alveolar abscess. It may occur with vital or necrosed pulp, but its origin is usually an exacerbation of infection with pus formation in an existing deep infrabony pocket. Let me repeat that. It may occur with vital or necrosed pulp, but its origin is usually an exacerbation of infection